right, so here's some information about TMJ. Um, the temporal mandibular joint. This is going to be the articulation of the articular fossa of the temporal bone with the condyle of the mandible. We do have an articular disc that lives between these two surfaces. That is going to be instrumental in moving as well as providing cushioning and shock absorption. And it is a synovial joint. We see it operate mostly as a hinge joint, but there is also gliding, which we'll talk about. The resting position of the mandible is going to be sort of the position that is an ideal position for your mouth to be in when at rest. So not when you're chewing or talking, but when you're just sitting, studying, watching this video. And so in order for the TMJ to be in the ideal position, we have to have that condyle sitting in the fossa of the temporal bone correctly. This means in a good position, our lips are closed, but the teeth are actually resting apart. So our mouth is not hanging open, but we're also not clenching our teeth together. This slight gap in our teeth is caused by the temporalis muscle working at a really low level. And then if our mouth is or if our TMJ is positioned correctly, when we open our mouth, we should be able to get 2 to 3 finger widths between our teeth. I'll let you take a minute and see if you can do that. And just know that everyone's sitting at home doing it together. However, sometimes people have an abnormal position and or an abnormal size of their mouth, which prevents them from being able to do that. But this is the ideal. When we look at the movements that are available, we can see mandibular depression, which is going to be opening the mouth, elevation, which is closing the mouth. Lateral deviation occurs with the mandible moving side to side. We can see protraction, which is like if you're trying to stick your bottom teeth out further than your top teeth, and then pulling them back is retracting. And then again, we talked about the normal resting position already. When we have mandibular depression or opening of the mouth, what we first see is that in order, the normal kinematics of that motion are going to be that the condyle rotates anteriorly on the disc first. Once it does that, it is then the disc and the condyle are going to glide anteriorly to allow you to fully open the rest of your mouth. If you don't have these normal mechanics of rotating and then gliding, we start to see dysfunction occurring in the TMJ. And people start having pain, they're not able to open their mouth as far, and a variety of other issues that they might have to come see us for. To elevate, before we go to lateral deviation, it's going to be a reversal. So as we start to close our mouth, the disc and the condyle glide together posteriorly. Once they glide back, then we have posterior rotation of the condyle on the disc to fully close our mouth. Excuse me. Lateral deviation is going to occur with spin and glide. So in this picture here, we have lateral deviation to the left. In order for that to occur, the left mandibular condyle is going to spin or rotate towards the left, whereas the right condyle is going to glide anterior medial. So it's going to glide to the left and forward. So essentially the left side stays and rotates in place without moving. The right side is going to go anterior and towards the middle. And then vice versa to go to the opposite way. It is important that you take a minute and you look at your bones or you revisit these landmarks if you have not looked at these before. We have a lot of bony attachments in these areas. So the mandible, we do have some articulations there on the temporal bone. The sphenoid bone, zygomatic bone, and then we have a combination of both to create your cheekbones, essentially, your zygomatic arch. Our maxilla is going to be our upper jaw. And then we also talk about the hyoid bone when we're talking about the TMJ. And if you remember, the hyoid bone does not have a bony attachment. It's suspended by muscles and ligaments in the throat area. And we'll talk about that here in a minute. And there it is. When you're palpating it, you're going to palpate just under the chin. You're going to kind of squeeze that soft tissue there. Don't squeeze too hard. And you're going to swallow. And when you swallow, you're going to feel the hyoid bone drop onto your fingers and then lift back up. Here we can see some of the ligaments that help support the TMJ. And so our lateral ligament, you're going to see up there underneath the zygomatic arch down on to the mandible. This is going to limit depression of the mandible. The sphenomandibular ligament is going to be internal in the mandible, so it's going to be deep, again, limiting depression. And then our stylomandibular ligament is going to come off that styloid process sort of below your ear area down to the mandible. And we have a joint capsule in the area because it is a synovial joint. We also have the stylohyoid ligament, which helps suspend the hyoid from the styloid process. The articular disc that we talked about, located up in the TMJ area, that, as we said, and then thyroid cartilages help provide support and structure to the anterior throat. The thyroid cartilages create the larynx and the various structures that we use for talking as well, but they're located below the hyoid bone. These are going to be the muscles of the TMJ. The four muscles there that are bolded are going to be the muscles that are directly in the area of the TMJ and control the opening and closing of the mouth and movements of the mouth directly, whereas your suprahyoid muscles and infrahyoid muscles are also going to control some of that, but they're going to assist and they're located outside of the jaw area. So between the jaw and the hyoid, and then below the hyoid down to the sternum and the ribs area. So our temporalis muscle is going to come off our temporal fossa. It's going to go dive below the zygomatic arch and attach on the coronoid process and the ramus of the mandible. When working together, we're going to elevate. It can help with retrusion when we look at those posterior fibers because they have an almost horizontal line of pull. They can help pull the mandible back into place. Unilaterally, they cause ipsilateral, so to the same side, lateral deviation. If you put your hand on your temporal area on either side and you pull your teeth together, clenching your teeth, you're going to feel your temporalis muscle kick into your hand. And it is cranial nerve 5, which is trigeminal nerve. And here you can see temporalis. Moving down to the masseter, this is going to originate on our zygomatic arch and zygomatic process of the temporal maxillary bones, going down to the angle of the ramus coronoid process of the mandible. So you can see it kind of like an X shape there. Bilaterally working together, they're going to elevate, whereas unilaterally they cause ipsilateral lateral deviation. This creates some of that fullness of your posterior cheek area. So again, if you clench your teeth and you're below your zygomatic arch, sort of in your posterior, on your, like posterior part of your jaw area there, you're going to feel the masseter pop out on your fingers. And this is also trigeminal nerve, cranial nerve 5. So there you see that. Deep to the masseter, we have the medial and lateral pterygoids. The medial pterygoid in this picture is the darker orangey color, and it's coming off the lateral pterygoid plate of the sphenoid and the tuberosity of the maxilla to running down to the ramus and angle of the mandible. Bilaterally, it's going to elevate and it's going to cause protrusion. Unilaterally, it causes contralateral lateral deviation, so it laterally deviates to the opposite side. Also, cranial nerve 5 trigeminal. Your medial and lateral pterygoids are best felt inside the mouth because they are deep. And so you'll want to make sure when you're palpating this that you glove up to palpate the pterygoids. Lateral pterygoid is going to be that more superior muscle here, off the lateral pterygoid plate and greater wing of the sphenoid bone to the mandibular condyle. And it also has an attachment on that articular disc, so it does help pull the disc whenever we go into depression, and also causes protrusion. So it helps keep that disc from being pinched. Unilaterally, contralateral, lateral deviation, and trigeminal nerve C5, or cranial nerve 5. Again, those are our main ones, but then we also have muscles that are assistive at the TMJ. The first set of muscles here are suprahyoid, in that they live above the hyoid muscle. And so the names of these muscles can tell us a lot about what it is attaching. So mylohyoid is going to be that wider light orange muscle here coming off the inferior medial, so inside the mandible down to the hyoid, helps with depressing, so pulling the mandible towards the hyoid, and it comes off the trigeminal nerve. Geniohyoid is going to be that darker orange, more straight up and down muscle there, coming off the mental spines, which is in the inside of the mandible, going down to the hyoid bone, helping with depression. It's a branch of C1 and the hypoglossal nerve, which is cranial nerve 12. Stylohyoid is going to be if you look up there, you can see the geniohyoid and the mylohyoid moving medial to lateral, and then you run into stylohyoid. Stylohyoid's coming off the styloid process down to the hyoid bone, and it also helps with depressed mandible. It comes off of cranial nerve 7, which is facial. Digastric is an interesting muscle in that it wraps around the hyoid bone, which acts as a pulley for it. It originates anteriorly off the internal inferior mandible and posteriorly off the mastoid process. Its insertion is the tendon that wraps around the hyoid bone. And because it loops around the hyoid when working together, it helps depress the depress the mandible. And it's coming off trigeminal and facial. So it's one of the few muscles that in our body that does act like a pulley. Then we have sternohyoid coming off the clavicle, the sternoclavicular ligament and manubrium up to the hyoid. We're now in the infrahyoid muscles. This stabilizes the hyoid bone. So it's not working to depress the hyoid bone. It's working to keep the hyoid bone where it's at when the suprahyoid muscles pull on the hyoid. And so it helps hold it in place so that those muscles that run from the hyoid up to the jaw the hyoid bone could be stable to then pull the jaw down. Coming off of hypoglossal as well as C1 through 3. Sternothyroid, manubrium, and glossal cartilage of rib 1 up to the thyroid cartilage. Again, indirectly stabilizing the hyoid bone. Coming off hypoglossal and C1 through 3 as well. Thyrohyoid coming off the thyroid cartilage up to the inferior hyoid bone. The thyrohyoid and the sternohyoid that we just talked about, or sternothyroid, sorry. Thyrohyoid and sternothyroid work together. And again, same nerves. Omohyoid comes off the scapula and it goes to the inferior border of the hyoid bone to stabilize it. Same nerves. And here you can see those suprahyoid muscles and the inferior hyoid muscles. You can see there the omohyoid has a tendinous band as well. There's a ligament that helps hold that in place to provide increased stability. And so when looking at the TMJ prime movers, thinking about how they work bilaterally, when working bilaterally, temporalis, masseter, and medial pterygoid are going to elevate, lateral pterygoid is going to depress. Lateral medial pterygoid protrude, temporalis retrudes. Part of retrusion is also just sort of the elastic recoil of the muscle. Ipsilateral lateral deviation. So this is when working unilaterally. It's going to cause ipsilateral lateral deviation of the temporalis and masseter. Contralateral is medial and lateral pterygoids. Sometimes people talk about, oh, I have TMJ. Well, really, we all have two TMJs because TMJ is just temporomandibular joint. When we're talking about a dysfunction, we need to add the dysfunction. So TMJD. And this is when people are talking about that pain and or movement or clicking noises. It can go as far as getting a locked jaw. And so there's a big spectrum of what TMJD looks like, and there's a big spectrum of how to treat it. Um, Usually we can see injury caused directly to the joint. So, for example, playing basketball, you take a basketball to the side of the face. That can cause direct trauma versus things like whiplash injuries because all of those muscles are in the neck area. Anytime we have damage to the neck, we can also cause an issue with the TMJ. Individuals that grind their teeth when they're sleeping and or clench their teeth, especially like with stress and anxiety, that can cause dysfunction. We can see arthritis occurring. It's a synovial joint can break down. We typically see this in women more than men, and especially in those middle age groups. We also see this with people that are like chronic gum chewers or people that chew food on one side of their mouth. This is an area of PT that's a little bit more specialized. We can talk in class when we're together about some very general exercises that we can give. However, if you find yourself working in a clinic that is seeing TMJD patients, you will want to do some continuing ed. This is one area that dentists can refer patients to physical therapy for. And let me know if you have any questions.